How are you guys doing tonight? Good? Hopefully. All right. I wanted to talk to you guys tonight about, in cardiac rehab, frequently people have barriers from their bone, muscle, and joints that kind of prevent them from really attaining kind of their goals for exercise. And so I wanted to talk at least a little bit about some of from my perspective, are some of the key areas for that. Give you a little bit of knowledge about some of the bigger complications, and then what you can do to kind of help yourself through it or work through the problem. So like I said, if you have questions while I'm going through it, I'm happy to answer them, but just so we can try and cover the whole content, we might have to keep moving on, or there might be some slides or whatever that I have that might actually answer your questions. So we'll see how we go. Does that sound okay? All right, so I just want to start by prefacing this. It's not an exhaustive topic. Bone, muscle, and joint health is a really big area. There's lots of things that can happen in lots of different joints in the body. So just wanted to let you know about that. And a lot of this stuff, because it's quite general, they're guidelines. So it's important just to interpret it in the context of whatever's going on for yourself or whoever you're asking about. And always speak with your treating physician if you have further questions about these kind of areas. So the outline for tonight, I wanted to talk a little bit about pain generators. So it's important to know where the pain's coming from to come up with a good treatment plan. Then we'll talk a little bit about muscle health and then a bit about joint health. And I wanted to focus on the hip and the knee. And then I just wanted to conclude everything with just some general principles for you to keep in mind going forward from tonight's talk. So pain generators, in terms of helping you and finding a way to treat the problem, it's really important to know where the pain is coming from. And so I'm going to use some medical terminology here. I'm going to do my best to explain it for you so that you can understand as best as possible. So things that are important to think about with pain. So at the top, there's acute. So it's limited duration pain. It shows up when something's hurting, like you bump your knee, and then it goes away in the time when everything's healed up. That's a normal response. I'm going to move your attention to the bottom and just point out the difference between chronic pain. And I'll come back to it again on this same slide. But that's pain that occurs beyond what you would expect with the particular injury or aggravation that you're experiencing. Within those two, there's two types of pain that we really try and think about. So one is called nociceptive pain, the other is called neuropathic pain. So the definitions are kind of here, so I'm going to try not to read them out too much for you. But nociceptive, so that refers to what we call nociceptors. So these are nerve endings that are designed to transmit the stimulus of pain, whether it's a little pinprick or it's temperature or whatever the disturbance might be. And so what they do is they transmit that sensation. That's due to either actual, so real damage that's occurring to the tissues, or even some potential damage. So again, if things are getting too hot, there's no necessary tissue damage, but you're starting to feel it, so you pull back away. So those are what nociceptors do. And there's different ways of breaking them down. Ways to think about it is what we call somatic pain and visceral pain. So somatic pain is something that we're all quite familiar with for the most part. So that's very well localized. It's usually stuff you feel on your skin. So you can identify where the area is quite clearly. It's kind of sharp or achy. It's usually overall a pretty well-defined type of pain. And then we have another type called visceral pain, and that's a bit more of the type of pain that's really hard for us to describe. You can't really tell exactly where it is. It feels like kind of in an area. It can be just kind of much more dull or deep. These are kind of some of the descriptions people will have for this type of pain. And so that helps us at least differentiate to a degree where some of the pain is coming from. Does anyone have any quick questions on nociceptive pain? I hope that answer at least give you some background there. Then the other type, and I'll have a picture for you to explain this on the next slide, is neuropathic pain. So nociceptors, they do their job. Their job is designed to sense pain. Neuropathic pain typically shouldn't happen. So what that is an injury to a nerve itself. So along the whole length of the nerve, or so either the peripheral nervous system, where they come out of the spinal cord, or in your central nervous system, which is your spinal cord and your brain. If there's any damage there, that can cause neuropathic pain. So it's due to nerve tissue damage itself. And that can give you different types of sensations. Some people describe this as burning, electrical, shooting types of pain. So this helps give us an idea of where the pain's coming from. And then going back down at the end to chronic. So chronic pain lasts longer than you would expect. It can either be nociceptive or neuropathic. and it can be very difficult to treat, unfortunately. Other aspects of it, it can actually be not only lasting longer than you would have expected to, it can also be out of proportion to what the injury actually is. So it can hurt way, way more than what the injury would have looked like it should have caused. And there's a lot of reasons why chronic pain is hard to treat, but these are kind of a good background for definitions for what that pain is. And so here, I wanted to show you just with a picture about what's going on a little bit better. So your nociceptors, so the nerve endings that are responsible for their job to transmit pain, they're right here at the ends where you would typically expect them to be if you think about a nerve. So that's where that pain transmission is going to come from. Neuropathic pain, so if you had an injury anywhere along the nerve, so if this is a peripheral nerve, or it could even be in your central nervous system, so this is a shortened version of your spinal cord, and up here is your brain. So that's where you would see neuropathic pain potentially coming from. And then chronic pain, I want to give you a little bit of a better idea of why it happens. So why does it last so long, and why does it feel worse sometimes? So what is important to note here, it's very small, but over here, on this diagram, the nerve comes in. It actually has to join up with the spinal cord. So the line isn't necessarily continuous to the brain. We call these synapses. Where this happens, you can see this other very tiny one over here to the side. So inside the spinal cord and other places where nerves join to meet other nerves, there's actually these things called interneurons. And these help what we call modulate pain. And when we say this, it can actually change how the pain is felt in the body, either increasing or decreasing the signal. And so in chronic pain, one of the theories is some of these interneurons here aren't functioning properly over time due to excessive stimulation from wherever either the injury is happening. The nervous system has an ability to remodel itself, and when you lose some of the normal functioning of the nervous system, that can lead to pain persisting for a long period of time. Does anyone is that reasonably clear? It doesn't explain everything about chronic pain, but just wanted to have some background on that. Okay, and then one of the last things I want to talk about pain before we talk a little about muscle and joints is just medications. So not every medication targets the same type of pain. And so this chart is here to try and show you some of the typical types of medications that we use and where they work and where they don't. So everyone's familiar with Tylenol or acetaminophen, that's the generic name. And it's particularly good for nociceptors, so the normal pain that we feel, again, when we bump our knee, bump our elbow, but it's not very good for neuropathic or chronic pain. Same with non-steroidal anti-inflammatory drugs, or NSAIDs, that's the abbreviation for it. It's really good for your nociceptive type of pain, but not neuropathic and chronic. Moving along down the line, many people are familiar with opioids, so they're used for lots of type of pain. They work both for neuropathic and nociceptive pain, but they're not very good for chronic pain. Again, now all of this needs to be taken with a little bit of a grain of salt because depending on the medical condition, this isn't a definitive summary of everything, but just kind of a good way to start to generalize things so that you can think about it. Procedures, so either injections, some people might have had joint injections before, or you had surgeries, you might have a joint replacement. Those are very good, again, for nociceptive neuropathic. There's another medication that's newer in terms of its knowledge called partial opioid agonist antagonists, and they're quite good, particularly for chronic pain if people are on opioids and they're on high doses and they want to remove those opioids. Another type of medications people might be more familiar with is called tricyclic antidepressants, or TCAs, and they're quite good for everything across the board. Again, all of this is about finding where the pain's coming from and the right indication. I'm going to talk a little bit later about medications in the class called SNRIs, or selective norepinephrine reuptake inhibitors. I'm sorry about all the medical knowledge, the medical jargon, but they're quite good for most types of pain in the right indication. Towards the bottom, we have medications called the gabapentinoids, and that's particularly known for gabapentin and pregabalin, some people might be familiar with. We use them a lot for neuropathic pain, and sometimes they're good for chronic pain as well. And also gaining popularity recently now are the cannabinoids, so medications that are derived from cannabis, and those are primarily good for neuropathic pain and a degree of chronic pain as well.
Question before you go?
Yes, sir.
I've seen Tylenol advertised, a subsection of it, Tylenol for arthritis.
Yes.
I was thinking that that would be in the chronic area perhaps, or maybe the neuro, I don't know. Why is it not in those areas and is the first area?
So tunnel arthritis is effectively, it's formulated for a longer lasting release overall. So that's the general idea behind it. The drug itself, the compound isn't changed. They find different ways of making it last for different durations. So that's, to my working knowledge, the primary reason. It's because it lasts the whole day, you only have to take it once. Now there's other, depending on the formulation, if they have other compounds in it. But
wouldn't that be chronic? Because you got arthritis all the time.
Correct. But it's still, so how do I say it? It's still, chronic pain again is, well, again, it becomes a bit of an overlap. So they can kind of transition from one to the other. It's like, so this is why sometimes for certain things it takes multiple medications, and again, really kind of trying to delve into what's going on and where the pain's coming from. Is it becoming chronic, or is there an ongoing injury which is still being properly transmitted to the brain? So, I want to talk about muscle health. These are a lot of things that you've been through the program, you're aware of, so I just want to re-emphasize the importance of these areas. So, things like warm up, making sure you warm up before your exercise. You don't want to stress your muscles too soon, so you want to give them time to get ready to accept exercise and whatever physical activity you're going to be doing. Then moving along to, again, stretching, making sure you're doing that regularly, keeping the muscles from getting too tight. Strengthening is obviously good for your muscle health. You want an appropriate strength for the activities you're going to be doing and for your functional goals. You may be familiar with FIT-P acronym, so it stands for frequency, intensity, type, time, and the progression of your exercise. And so, again, that means you're doing your exercise the appropriate amount of times per week at the right level of intensity. You know, the amount of time that you're actually spending doing that activity, what activity it is. So again, what you exercise is where you derive the benefits, so it's specific. And then how do you progress that? And so again, it's moving your activity forward until you reach a good level of maintenance for yourself. Other things you can do for muscle if you're feeling some aches and pains after exercise, people are usually familiar with. So either cold packs or heat packs can be very helpful. It's always important to remember good technique. So whatever you're trying to in terms of building your strength, make sure that you're following appropriate and safe technique for that, and then using the right equipment. So if you're running, making sure you have appropriately appropriately researched and good new running shoes or whatever equipment you need for whatever activity you have. So the next thing, now we're going to talk a little bit about joints. So this is a hip joint. You're going to see it again later. The things I want to draw your attention to quickly right now. So this is called, I'm going to talk about this. This is the acetabulum is where your hip, so the ball and socket joint here. So this is the ball. It sits in the socket, which is called the acetabulum. This is the head of the femur. The blue is the cartilage that's covering it over. And this is the femoral neck. Over here is called your greater trochanter, and this is the shaft of the femur here. And so I wanted to start, before going any further into joints, just talking about what osteoarthritis is. So this is the definition that could be useful for you. So it is a progressive, non-erosive disorder of joints, and it causes deterioration of the joint cartilage, so what you saw in blue, also with typically associated synovial inflammation with or without thickening. So your synovium is part of the tissue that is makes up the joint space. In the area that encloses the joint space, and then bony changes as well, which can include new bone formation at your joint margins. And I'll show you a picture later just to give you a better illustration of that. Typically in osteoarthritis, the cartilage is the first thing that is affected. And it's also good to know that osteoarthritis is a clinical diagnosis. So we do other tests, and particularly x-rays. All that is to try and confirm the diagnosis. But it is a clinical diagnosis, so it's based on the physical exam and the symptoms that the patient has, with supporting evidence as well. So some of the risk factors people would wonder about. So some things you can and can't control. So age, as we get older, our risk for osteoarthritis increases. There's not much you can do about it. No one's been able to reverse aging yet. I'm sure once they do, you will all know, as will I. Gender can be a factor as well. So some types of arthritis appear to be more frequent in females versus males, particularly knees and hands in females. Occupation can play a factor too, particularly if you're doing either very strenuous, high-impact activities, and then having a higher than normal body weight puts extra force through the joints and can cause some wear and tear. Previous injury. So if you've ever had so you can have either an infection in your joint space, if you've had a fracture that goes into the joint space, even sometimes if you had a ligamentous injury around the joint, this can sometimes predispose you to osteoarthritis. Sporting activities, much similar to occupation. If your joints are under a lot of stress, it may lead to increased risk of osteoarthritis. And then similar to age, genetics, some people have particular gene encodings which appear to be at higher risk for arthritis. It's a very complicated subject, and there's still a lot of research going on into it. So I won't go into any further detail other than that, but sometimes we're just genetically predisposed to it, unfortunately. And then muscle weakness. So if your muscle isn't able to control the joint, sometimes you might end up putting force through it in an unusual manner, which could cause, again, arthritis, again, by poor force distribution or bad biomechanics. So a lot of times we order an x-ray. So I wanted to let you know about some of the features that you typically find with osteoarthritis on an x-ray, and I'll explain some of these terms for you. So one of them is asymmetric joint space narrowing. And so what that means is basically symmetry implies that both sides look the same. So with joint space narrowing, there's going to be one area which is more narrow than the other. That's one of the classic signs for arthritis on an x-ray. As well as you might hear terms such as things called osteophytes. Those are the new bone formation that occurs in the joint margins. And I'll have a picture shortly just to show you. You may also hear that there might be a loose body. A loose body is either a piece of cartilage or bone that's floating free in the joint space. And that can be an indication, again, of some cartilage damage. It's been worn down and a little piece is broken off, and now it's just kind of sitting in there. And that can cause pain and also lead to osteoarthritis as well. Subchondral sclerosis. So for this definition, subchondral, all right, so chondral refers to cartilage, sub refers to beneath the cartilage, and sclerosis refers to a thickening. So beneath the cartilage, there's a little thickening of the bone, and you can see that on an x-ray. Same with the next line, subchondral cysts. So again, sub, beneath, chondral is cartilage, and a cyst is a little fluid-filled cavity. You can find those inside the bone as well in people with osteoarthritis. A key feature for you to remember, again, if someone's telling you about all this, that what is seen on the x-ray doesn't always match up to how you feel. And that's quite common. So some people have x-rays that look quite serious, and it looks like there's a lot of osteoarthritic changes there, but some people feel absolutely no pain and they don't notice at all. Other people have entirely normal x-rays and all their clinical symptoms indicate they have arthritis. So the x-ray, even if it shows some of these things, doesn't necessarily correlate very well to how you may or may not feel. Which is again why arthritis is a clinical diagnosis, because the x-rays and other investigations aren't definitive in terms of diagnosing it all the time. Does that make sense, or does anyone have any questions about any of these terms? Because they're, they're pretty medical, so. Okay, all right. So, I'll start with hip osteoarthritis. So this is the hip. You'll see it again in a second, but I just wanted to highlight for you. So in the blue, these are little lesions or little areas of broken down cartilage, and these are the osteophytes, these bony projections on the edge, on the joint margin edges. It's not impossible to include all the radiologic findings because some of these are underneath the cartilage, and so you can't see it on a normal picture. But for the hip, so where do you usually find the arthritis? So it's usually at the superior lateral joint space. And so what that means is, in the word, so superior is up, lateral is to the outside of the body. So that's usually where you're going to find the early changes of osteoarthritis. And then what do you feel? So People typically report pain with activity. It's usually, so when you're up and walking and moving, usually it's better with rest. And then where you feel it can be quite misleading. So you can feel it in the groin, it can be in the buttocks region, it can be in the thigh. So it's not necessarily, it's in the hip, but you feel it in different areas. And so that makes the diagnosis much more difficult. It feels like a lot of other things which I'll talk about shortly as well. So you might also note some instability in the hip, like it just doesn't feel quite right. It feels like it's going to give out. Some people notice some locking or catching, like it just, they can't move it properly, or it feels like it gets stuck. Stiffness is not uncommon. And then restricted range of motion. In particular, most people don't check this, but internal rotation is typically the first motion that's lost with arthritis. And so that is where you take your foot and you try and turn it inside, and then that can get reduced early on compared to the other side, assuming the other side is normal, as a sign of arthritis, osteoarthritis in the hip. And then sometimes in very severe cases you can actually lose some muscle around your hip as well. And so again, just to re-emphasize some of the points, so again, the cartilage damage here on top of the blue cartilage, and then so the osteophytes are around here. So, what are we going to do about it? So there's different things that you can do. And there's quite actually a lot of choices. Not everything works for everybody. So a good way to think about it is what is either non-pharmacologic, so drugs, or no drugs. So from a non-pharmacologic, so no drugs, it's always important to get some education. So, it's okay to ask your physician about what you have so that you understand what the process is, what to expect. That always makes it easier to deal with symptoms and your treatment plan and what you're going to do going forward. Some people require activity modification. So osteoarthritis is progressive. We can't reverse it yet. So sometimes we might have to either change how we do our activities or find other activities depending on your goals for activity and movement, sports or exercise. Pain coping interventions can be very, very useful. So some of this is the unfortunate reality is in life. Sometimes we have to accept some pain and discomfort, and because there's only so much that medicine and treatments can do for you. And so some of those include mindfulness. So someone might have talked to you about meditation. Others such as cognitive behavioral therapy. There's many choices, but finding ways to become just kind of coping with your pain, accepting it and learning how to deal with it can help improve your quality of life overall. And then exercise can be quite beneficial. So strengthening the muscles around the hip can help control the pain, control the hip joint, and reduce symptoms. In particular, some people find that they have a lot of hip pain and they can't even really start with that. So aquatic exercise can be very, very helpful. It's, you're in the water, you have all that buoyancy, it reduces the stress on the joints, and suddenly you find you can move around and do activities, plus the resistance of the water can also help build muscle and increase physical fitness. Likewise, Tai Chi, a low impact exercise, can also be very helpful for strengthening the hip joint area, and can be helpful for controlling some of your pain symptoms. Because, again, higher body weight can lead to arthritis, so weight loss not to an extreme degree, but a modest degree can help with symptoms, just reducing the amount of force that goes through that joint. And then also an assistive device. So nobody wants to have a cane or any other extra tools for walking around. But they can help reduce the load through the joint. There's the Nordic walking poles as well. It can be very helpful, and that can improve some pain symptoms as well. And then, depending on, again, how you're feeling and if it's useful, local application of heat can be helpful as long as it's done safely. And then from a pharmacologic or medication side, so nonsteroidal anti-inflammatory drugs are typically helpful. Tramadol is a medication that can be useful, so it's known as a weak opioid. It's used reasonably because there's less concern about addiction and other negative effects from using opioids, so it's one that is used more often. Duloxetine, that is one of the SNRIs, or selective norepinephrine reuptake inhibitors, in the category that I mentioned, can be useful. And then corticosteroid injections have some evidence as well as for helping for osteoarthritis in the hip. So that's where you take a small amount of corticosteroid and it's injected directly into the joint space, so you minimize the side effects and hopefully get the pain reduced. So a lot of people are worried about corticosteroids when they get an injection. Because it stays primarily in the joint space, you don't have to worry about the big, scary steroid side effects that a lot of people have heard about and are very real. So there's a reason to ask about that. Now, those are some that have pretty good evidence for it. Nothing is perfect. So usually, because pain is coming from different areas and it can be overlap from acute pain or chronic pain, it usually takes a number of modalities or different treatment plans to try and bring that together to reduce pain. Some things are uncertain though. So acupuncture may or may not work. Glucosamine and chondroitin, a lot of people have heard about it. A lot of people try it. Again, depends. A lot of these things with arthritis and bone muscle joint problems, it depends who you ask. So again, this all needs to be taken with a grain of salt. It's either neither good nor bad, presumably. Same with various nutritional supplements. That's a catch-all phrase I just kind of put in there. Even Tylenol, acetaminophen is kind of a little bit hit and miss depending on which study you read and who you talk to. And then another thing called viscosupplementation. So that's where you take a synthetic joint fluid and you inject it into the joint space with the idea to basically add extra lubrication. And there's some other effects that it presumably has for reducing pain in the joint, but that's the overall intention for it. So think of it as like just kind of, if you're going to oil your car, well, you're trying to oil your joint. Obviously not without actual oil. Things that we don't recommend are strong opioids, just because, again, always concerned about side effects and, again, addiction and other concerns with opioid use. And then ultimately, sometimes people need a replacement. So that's typically a hip replacement. There's different types. I'm not going to go into that in detail, but if you need to see an orthopedic surgeon, then that's the right time, and you can talk about the various treatment options that they may have to offer if that's a necessity for you. Any big questions about? Yes, ma'am.
Question. Where would Celebrex fit into all this?
Yes, Celebrex. So that is a non-steroidal anti-inflammatory drug. So that would be that is a recommendation. So, yep, it's in this category. There's lots of different types of non-steroidal anti-inflammatory drugs. Celebrex is one of them. So some other hip stuff that you may or may not know about. So not everything is arthritis. So I want to tell you a little bit about labral tear. So first, what is the labrum of the hip? So it's highlighted in green here. So this is an extra bit of tissue that extends around the ridge of the acetabulum. That's the socket where the head of your femur sits, and it provides an extra amount. Basically, it helps keep the head of the femur stable in the joint. So it helps maintain the bone from flopping out of the cup in which it sits. And so it's actually quite important for your overall joint health. And so sometimes it gets torn. So where it gets torn is typically at the anterior superior aspect. So anterior means the front of the body, superior means up, so it's at the front and the upper portion of it. And then why does it get torn? So it can happen from trauma, so if there's just kind of an accident or whatever. It can also happen from degeneration of the joint. So again, we're talking about hip arthritis. Some of those osteophytes, if they're rubbing along the labrum, they can actually cause a labral tear. So potentially. As well as if you're a hip joint capsule, so some of the ligaments and things that help keep your hip in its place, if they're loose, it can wobble around, it can kind of fray on the labrum, and again cause a tear. So what does that feel like? Well, it's not easy to tell the difference. There's pain typically with flexion, so bring your hip up forwards. Sometimes people feel kind of just a vague sensation in the groin and not really sure where it's coming from. Some people feel a snapping or even a locking sensation, and again, can be quite similar to how osteoarthritis sounds. And so again, this is your labrum, and so again, the tear will typically happen in the front aspect and towards the top. And so what do we do about that? So again, a lot of these treatments you're going to see are reasonably similar. So relative rest. So sometimes you need to take a break from the activity that you're doing. sometimes you need to modify the activity that you're doing. And then strengthening the area again can be helpful, so some physiotherapy, strengthening exercises can be useful. Non-steroidal anti-inflammatory drugs again are another modality that we will go for in terms of treating it. And corticosteroid injections can be helpful with this. They can be both diagnostic to help isolate if that's where the cause of the pain is, and it can also be helpful for treating it, so therapeutic as well. From an operative standpoint or surgery, typically it's either it's a repair. So usually we want to conserve it as much as possible. So if at all possible, save it, so repair it, and if not, take off as little as necessary to improve the symptoms and then save everything else. Are there any questions about labral tear that anybody has right now? Okay. The last thing for hip that I wanted to talk to you about is another thing called FEMORO-ACETABULAR impingement. And so what I want to highlight in this picture, and it'll be coming up again, is this area in green. So this is, you can see where the normal femoral neck is. This area in green is to imply extra bone that wasn't supposed to be there. So it's thicker. Okay? And likewise, the area of green on the far right over there, that's implying that your normal acetabular ridge here is actually, there's more bone than there should be. So there's less space for when you move your hip joint around. And those contact each other and can cause pain. So that's what the problem is. So deranged contact of the femoral neck, which was thickened, against the edge of the acetabulum, which may or may not be thickened. So it can be one, it could be the other, or it could be both working together to cause this type of pain. And so that, again, from what does it feel like, much similar to what we discussed with the other two. So you're feeling pain in the hip, you're feeling pain in the groin, sometimes in the buttocks or the gluteal region. It's worse with flexion, just like the labral tear, unfortunately, so it's hard to tell. Some people, though, find they have trouble sitting for long periods of time, especially when you're driving in your car. They find that at the end of the car ride, they feel really sore and things just feel quite a bit worse than before they started. And some people might notice decreased ability for hip flexion and internal rotation. So again, just wanted to emphasize the point. So that's thickening of the femoral neck and then thickening of the acetabular ridge. And so when you're bringing your hip up, these two are contacting each other, or basically impinging structures and causing pain in that region. So what do we do about this one? This one, not as much is very useful for it. So really, if you're having minimal symptoms with this, we actually recommend just observing for the time being. If it's not impacting your life in a great deal, then don't interfere too much. Otherwise, modifying your activities, strengthening the area again. It's a lot of the same stuff I've already mentioned. But the definitive treatment is actually going in and shaving down the areas that are causing the problem. So it's usually more of a surgical treatment for this one. Any questions? Or? Okay. So that was a lot about the hip. I want to talk to you now about the knee joint. So knee problems are also quite common in people. So this is your knee without their kneecap or your patella on it. So this is the sorry, you're starting to use medical terms. The end of your femur. The blue is the cartilage at the end. This is the top of your tibia, and this is cartilage on the tibia as well. And then over here, this is the top of your fibula. And you'll see some more pictures later as well. So the first thing I wanted to talk with you about is meniscal injury. So it's quite a common problem for people. I didn't highlight in the knee diagram, but it's here in green. So on the far left for you, sorry about that, you can see your knee joint. Now sitting on top of the tibia, so that's the lower big bone, on top of the blue cartilage here in green, these are your menisci, okay? So the way this is oriented for here, so the bottom is the back, the top is the front of your knee, and then so the The large one on your left, that's the medial meniscus, so the one on the inside of your knee. This is the right knee. And then this on the outside, this is the lateral meniscus, so it's on the outside of the right knee. And then this is your posterior cruciate ligament and your anterior cruciate ligament, ACL or PCL. You might have heard of those terms before. We'll come back to this picture again in a second. I'm going to talk to you a little bit about what can go wrong. So, what's going on in the knee? So you have two menisci, so two places for injury. The medial meniscus, so it's usually associated with what we call cutting maneuvers. So this is where a lot of people may have watched basketball or watched soccer or football, depending what you want to call it. So that's where your people, athletes, or just normal, we have to put our foot down, it's flexed a little bit, and then we turn and we're trying to pivot. This happens in normal everyday life as well, and that causes typically medial meniscus injuries. On the other side, you have your lateral meniscus, so on the outside of the knee. And that's typically caused by injuries. It's a little harder to do. You actually have to have your knee, again, typically, but all sorts of strange things happen with your full flexion, and then you rotate on the knee. So with the medial, you just need a little bit. With the lateral, typically it needs to be bent about as far as it can go, but there's a lot of variability there. Those are two acute injuries that you can have. With time, you can have degenerative changes, and you can have degenerative injuries. So the meniscus is degrading over time, and so sometimes that can happen just when you're doing your normal stuff. You're just walking, you didn't do anything, and then suddenly something doesn't feel quite right. And usually it happens on the medial meniscus, so the inside of the knee. What does that feel like? So depends which one's hurt. So if it's either the medial on the inside or the lateral on the outside, that's where you'll be feeling the pain. You might be feeling some clicking, some locking, some swelling, or some instability to your knee as well. So going back here again, so this is the lateral meniscus, this is the medial meniscus. For the next slide, I want you just to keep in mind how the meniscus is shaded. So, and it's going to be important to remember, for some treatment options, you need to divide it into thirds. So it depends on how much blood flow gets to the meniscus. So the outer region in green, that gets the most blood flow. The inner region of the meniscus typically doesn't have any blood flow at all. And so that'll be important on the next slide when I talk about how we treat some of these injuries. So first, what do we do without operating on it? So again, a lot of stuff with bone muscle joint is quite similar. We're going to do a little bit of relative rest. So take a back step from whatever activities you're doing. Don't push it too far. And then strengthening can actually be very, very effective for a meniscal tear. It depends on the type of tear. It depends where it is. There's a lot of contextual factors that need to be considered when you're going to be treating a meniscal tear. But in the right indications, doing leg raises and strengthening the area around the knee can be very useful for improving symptoms for a meniscal tear. Some people need bracing, especially if there's a lot of instability to the knee and you're worried that you're just not going to be able, it's not going to carry your weight. And then if pain's a major issue, again, back to non-steroidal anti-inflammatory drugs is generally a go-to with bone, muscle, and joint problems, as long as it's safe, depending on the overall medical condition that each person has. Operative treatment is done for these injuries as well, and this is why I'm talking about where the blood is going in the meniscus. So if you injure the inner 2/3 of the meniscus, because it doesn't receive much or any blood, typically it has to be taken out. Again, that's a generalization. Sometimes it doesn't. It really depends. It depends how big the tear is, how thick, where it is, what your symptoms are. But that's kind of a generalization. If it's on the outside, that has good blood supply, so it's typically tried to repair that. And those are the kind of the general way of looking at it from an operation standpoint. Any questions about the meniscus?
So if you remove it, then how do you function?
So that you try and remove as only what is needs to go. The more you can keep, the better. because the meniscus, it helps keep the end of the femur stable in the knee. So the knee is a very complex joint, and it carries a lot of weight and a lot of forces go through it. And we really need it for a lot of the things we do. When we don't have it, we notice how important it is, just like a lot of joints. But that's where, if you don't have your meniscus, then whatever ligaments you have remaining, and particularly the anterior cruciate ligament and the posterior cruciate ligament, become more of the primary stabilizers of your knee, and they're what you're going to rely on for keeping the knee in place, along with other ligaments in the joint capsule. But that's basically, other things have to take over for the lack of the meniscus if it's gone. Does that answer your question?
You'd think there'd be something that they could insert these things, like.
Yeah, I mean, there's I wouldn't be surprised if it has been tried, but I don't know any information on that, so I don't know. Certainly, if they can come up with something, they will as soon as possible, because it would be a great benefit to a lot of people. Yes, sir.
What's the difference between cartilage and meniscus? I don't want to. I want to answer this as accurately as I best can. If you want to get down to the nitty-gritty of it, it's going to be probably down on a cellular level about, how, like, the types of fibers that are located in it. But I mean, the meniscus is particularly so. You can't see it on this diagram. I want to just. It helps. Basically, it helps. I'm going to walk over here for a second. It kind of cups the end of the end of the femur here to try and hold it in place, add some extra stability. It's not the same cellular material as cartilage. Again, some parts of it do have a blood supply, which cartilage does not have a blood supply. So there's different there's different basically cell types is what it is. Both in the knee?
They're both in the knee, yes. You have joint cartilage in the knee, and you have the meniscus as well. Yes, sir.
Years ago, they said they removed the cartilage in my knee. Does it grow in again?
Cartilage does not return, unfortunately. No.
So you can live without it?
You can, yeah. And again, similar to what I was saying with osteoarthritis and some of the x-rays, like, some people don't have any cartilage in their knee left, and they don't actually feel any pain. So there's a lot of variability in how people experience different types of bone, muscle, and joint problems. And so, if you have no cartilage and you're doing okay, then that's excellent. But some people have minimal cartilage damage and feel quite a bit of discomfort. So there's a lot of variability overall.
Pieces floating around in there?
There could be, and those are called loose bodies if we see them on imaging. So, and again, those may or may not cause symptoms. So just because we see something doesn't mean it's necessarily a problem, or it can be hard to identify which one is the problem. Is like, if someone has a very painful knee, is it the fact that there's no cartilage there? Is it the fact that there's a loose body floating around? Is it the fact that part of the meniscus is gone? It's hard to tell. Yes, ma'am.
So what happens when you have a knee replacement?
Sure. Okay. So, one second. It depends on the type of knee replacement. So you can replace all or some of the knee, so it really does depend on what's getting replaced. You can replace certain areas of the knee and leave the others intact. Otherwise, you can also take out. If you're going to do a total knee replacement, then basically the joint surfaces are cut out, put in with synthetic knee components, which are secured into the remaining bone, and then then they basically try and use the ligaments that remain. You have to take out some ligaments in the process, tighten them up to try and simulate as much as possible the normal knee mechanics, and that's a total knee replacement overall. But you can have partial knee replacements as well. So. I can't answer that question quickly either. I'm sorry, ma'am. Yes?
So what are key avoidance strategies for these conditions?
Right, sure. So for meniscus stuff, so again, a lot of it is, ensuring you have some of the stuff I started from muscle health. So good biomechanics, proper footwear, making sure your muscles are appropriately strong for the tasks you're going to undertake. I mean, there's only some things that you can prevent or avoid, unfortunately, with some of these. So with some of these things, like some people,
depending on your line of work or just your body type. So alignment of the knee can play a factor in avoiding some of these things. So some people are just born, you may have heard of people with like knock knees, or some people are bull-legged. So those can lead to different, because the forces are distributed differently through the knee, some people can develop knee problems with that. So it's about, you know, as best as possible, just trying to maintain your overall strength, protect the joint, not put it through too much stress. But there's no perfect answer for that, unfortunately. Does that kind of answer your question, or is there?
Yeah, like it's so strengthening.
Most.
Just with resistance training.
Yeah.
Such as weightlifting or water aerobics or that kind of thing.
Yeah, it's going.
Then there's also this whole movement. I don't know if you're familiar with Katie Bowman, who does a lot of like alignment work, and there's a woman that does some of that work in Toronto as well. And her thing is like you can fix all of those things. Like if you're bow-legged, you can fix it with certain stretching and alignment exercises and that kind of thing. And I'm getting the sense that you're not. What do you think
About alignment issues?
and like fixing?
So it depends on what the. That's a. Yes, it depend. It would depend on what the alignment issue is, how severe, what are the risks and benefits, and depending on what you're going to intervene with as well. So, for instance, I mean, you can make surgical corrections to bone alignments that are not optimal. So typically they're called osteotomies. However, every surgery comes with its own risks. And then even other things, so like if you're going to correct like, say, foot issues, so if someone has, say, flat foot, that's a common one. The concern is that when you intervene on one area, you might cause a problem somewhere else. So it's about making sure that you really evaluate the risks and benefits carefully before you start with an intervention. And that's why it's very important to try and be as specific as possible about what the concern is, what the problem is. And again, going back to some of the things I've said as well, is that it's very hard to predict what will happen in the future about a lot of things, including joint problems. Again, going back to the fact that some people have abnormalities on their x-rays, but they don't feel any pain or discomfort. So you run a risk of predicting a problem which might not show up. And so it's always important to have a good discussion with your treatment provider about what's important to you, your value set, how concerned you are, and the risks that you're willing to take for the potential benefits. So does that kind of address your question to a degree?
Yeah. And this woman also says that you can damage in the gym by doing exercises improperly.
Yep.
Like it just feels like this like cycle of like, well, what do you do? Like, sit on the couch. Right?
That's correct. And then so there, I mean, the other thing is everybody has we all have different, like there's all sorts of various factors that go into it. We all have different body types, our weights are different, even our gait mechanics, how we walk and we distribute forces, all different. And because all these factors come together, it can be very challenging at times to really identify what could be a potential problem and what should just be left alone. I hope I'm not going on a tangent there, but yeah, like at the same time, you can't just live in fear and sit in your home, right? You gotta. There is a risk every time you exercise. Yeah, you can do damage to yourself. The hope is that the benefits of having good aerobic capacity, a reasonable amount of muscle strength outweigh the risks that you're undertaking with that particular activity. So it's about, again, finding something that for your activity that's something that you enjoy, that you're willing to keep doing for the long term, and that you feel is a good enough safety profile for you. And go out and do that. Enjoy your life, be happy. We want, you want to get out there and do the things that are important to you. So another thing for the knee, this is a common one as well for people. So patellofemoral pain syndrome. So this is kind of a catch-all for a lot of potential issues. I'll describe in a second. On the far left is your regular knee. On your right, this is the knee from the side. So looking at it from the outside to the inside, I've added the kneecap here for you. So the patellofemoral joint is the articulation or the contact area between the back of your kneecap, your patella, and the front of the femur, two areas with cartilage on it in blue. And so that's the location is what I just described. You can also call it the trochlear groove of the femur. And from a pathology standpoint of why it's hurting, so it's thought to be a number of things can cause this. So it can be cartilage damage. It can be tracking problems with your patella. So it's not sitting in that groove properly. If it's too far to one side or too far to the other, or it's wobbling around, that can cause pain. Muscle weakness or excessive tightness. So if your muscles aren't pulling it in the groove properly, or they're pulling it too much, again, kind of similar to a tracking problem. You're talking about joint alignment. So again, if you're depending on how your knees are. So if your knees aren't well aligned, so some people have knees that are just too excessive knock-kneed or too bull-legged, and so those may or may not require correction. It depends on, again, your symptoms, your stage of life, your personal goals, and the risks involved in trying to treat that. Some are not as severe, so some can be corrected with other interventions. And then even just simple stuff as overuse or overtraining. So exercising too much, putting too much strain through the joint can even cause it. What does it feel like? Vague pain. It's really hard to define. It's typically in the front of the knee. It's usually worse with stairs and even sitting for a long period of time. Also can be worse with squatting, running. So again, anything where you're really using your knee a lot, but even if it's just being bent for a long period of time. And so again, just kind of highlighting again all the areas that are kind of the cartilage, the tracking. So tracking, if you can imagine it on your far left, just kind of in the middle where you kind of see the peak of the blue, that's the groove. And so if it's not sitting in that groove properly, it can cause issues, or if it's pulled too far to the other. And so what do you do for it? Well, there's a lot of problems that can cause it, so there's a lot of ways to try and tackle it. Modify your activities, as I mentioned before. There's some things you can do. So strengthening actually seems to be quite useful for this, particularly targeting a specific muscle in your quadriceps called the vastus medialis obliquus. And so you can do that with what we call short arc exercises. So again, trying to really focus on the muscles that are on the inside or the medial side of the knee. Taping and bracing can be helpful. Icing can also be helpful. NSAIDs, as I mentioned before, usually a go-to as long as it's safe. And then operative treatment is only done for this one if we know really where the pain is coming from, because you can't go back from an operation. You can't undo what was done, or I should say that, often you can't undo what was done. So if you're going to do things like release the lateral retinaculum, which is a ligament that helps hold the knee in place from one side. If it's too tight, you might want to release it. Or you might want to debride or take some extra tissue or bone off that's getting in the way. You might want to realign the patella. You might even want to kind of basically reconstruct it with an arthroplasty. Yes, sir?
What would it be when you go to get up and your knee just gives out on you, and then after a few minutes everything is fine?
It's like any one of the above, and we're going to talk about our knee arthritis in the next slide. So that's why, like, all these symptoms, one of the issues with bone muscle joint problem is a lot of these symptoms feel the same, or it's really hard to tell, or they're described similarly, because again, it's when you're dealing with structures that are underneath the skin, they're not always localized so well, and they're not, again, like we're talking about on the earlier with kind of more of your very clear. So bone is well innervated, but even still, it's where you're feeling it is not always well localized, not like your skin. So it's hard to tell where pain is coming from typically.
It's not a matter of pain, it's just a loss of going down the stairs and just the knee gives out.
Yeah, and so your knee can give out again from instability due to a meniscal tear. It can be due to, some people even have knee giving out can sometimes be a symptom of arthritis. Some people don't feel their arthritis, but they have it. And the muscles, because there's still damage and irritation, the muscles can actually release and just give out because they want to avoid hurting themselves. So there's some intrinsic processes in the body, feedback loops, that can cause things like knee giving out without any pain. So even like pain, it's literally like pain that you don't feel. Can actually cause some of these things. So it can make it, yes, sir?
Are there any cushioning fluids in the knee? Like Baker's cyst is one of the things that you can get if the fluids move out or something.
Yeah, so a Baker's cyst is an outpouching of the, basically the sac that holds the lubricating or synovial fluid in the knee. So yes, you have every, I'm going to take that back. Not all joints have a lubricating fluid. The ones that we're mostly familiar with as joints, like our knees, our hips, they all have a lubricating fluid called synovial fluid. And so that's always present there. And the lack of it or a lower level could potentially cause pain. But does that kind of answer your question? Or there is a lubricating fluid for sure. So.
So they ever remove the synovial fluid?
I couldn't see a reason for that. It's a lubricant. You want it there. So, yeah. Oh, so a question. Yes, sir.
Yeah, does taping work? I mean, just a piece of paper, right? So
Taping? A piece of paper?
just some tape on it.
So typically we use like quite strong tape. So there's different types of tape products that are used specifically that are very adhesive to the skin, have good resistance as well as elastic properties, so they can really help support structures. But it also depends on, again, using the right type of tape. You're taping it in the appropriate manner. So there is a technique to taping as well. So all of these, a lot of the things that I'm mentioning, again, it's very general. I apologize, it's got to be superficial because to go into depth, we just couldn't cover it in a night that you would be willing to sit in this chair for. But yeah, it can be helpful as long as it's applied properly. And again, if we know as best we can, we know what's going on. So the last one for the knee, we'll close out with osteoarthritis again. So this is an osteoarthritic knee. There's going to be a lot of features you're going to see. So cartilage damage, osteophytes. And so where is it happening in the knee? So there's three spaces we think about for arthritis in the knee. The medial joint space, so that's on the inside of the knee. Then we have the lateral joint space on the outside of the knee. And then we just talked about it, the patellofemoral joint as well. So three areas where arthritis can show up. It can show up in one, two, or all three. It really depends. And how does it feel? You're starting to get the picture like everything else I said so far tonight. Pain with activity, may or may not be well localized. Typically it's on the front of the knee for arthritis though. Swelling, stiffness, instability of the knee, locking, catching. You can even see, again, if it's advanced or it's getting worse, you can see some deformity, so bony outgrowths. That's the osteophytes. Because the knee there's not a lot of extra tissue between the knee joint and the skin, you can typically see the bony outgrowths. And some people have larger knees. And you can feel it when you push on it. It's just kind of, it just feels really firm. It's like more bone. There can also be some loss of the muscle bulk or atrophy around the knee as well. And so again, going back to the picture, just re-emphasizing some points. So cartilage damage that you can see, osteophytes. So again, these are these bony outgrowths along the joint margins. And that's all I can really draw for you, but there you go. So for knee osteoarthritis, what do we do? There's a few, it's similar to the hip, to be honest, but there's a few more options you can take. So just running through the list again, education. Pain coping mechanisms, so again, mindfulness, CBT, meditation can be very, very useful, not to be ignored. Exercise programming, strengthening, aquatics to take that extra load off the knee, Tai Chi. Now here's another one to add on, bicycling. So really strengthening the quadriceps muscle can be very useful for controlling knee pain for osteoarthritis. Bicycling is quite good for that. So on a stationary bike, if you feel comfortable, it can help. None of these things, important to remember, none of these are going to be overnight. It's kind of like all this strengthening, conditioning, it's going to be over time. You might notice that you can do more activities than you used to a couple months ago. So it's not going to be instantaneous relief, and very rarely does one thing really provide total pain relief. Weight loss, as I mentioned before, assistive device such as the Nordic walking poles, and heat if it's safe. And then from a medication standpoint, for the knee, because the joint space is so close to the surface of the skin, you can use topical medications. So this is some of the rub-on stuff that you may have used or seen. So you can buy over-the-counter things. So Voltaren is one of them that you can get. You can rub it on. It's not necessarily going to work, but because the hip is so deep inside, the topicals don't really work. Just can't make it that far down. And so another one is, any of the topical non-steroidal anti-inflammatory drugs, there's a couple out there. Topical capsaicin, you may or may not have heard of it. This is actually a derivative of the pepper. And so it's not very pleasant to use, I'll be honest, initially. It takes some getting used to. It burns. You apply it with gloves and not touch your eye, okay? But what it does is it effectively, to put it the best way possible, it actually overstimulates the nerves and can help decrease the pain. So that's one way it can work. Then you have your NSAIDs that you take by mouth, tramadol, which we talked about, duloxetine, which is one of those SNRIs, and then a corticosteroid injection can be helpful. There's things that we're not too sure about. Those are some with more of the best evidence. Now, we're talking, going back to, there's some comments about alignment. So, insoles. So, certain types of insoles can help. So, if you have lateral knee osteoarthritis, what we call medial wedge insoles can be helpful. However, I want to just showcase that not recommended is lateral wedge insoles for medial osteoarthritis. Sorry, that's kind of confusing, but apparently, from the studies that we've got, there's only one. It only works for lateral, unfortunately. Bracing can be helpful. So a lot of people have seen the sports knee braces, as well as, yeah, they can provide stability. Now TENS, I apologize for not writing that out. That stands for transcutaneous electrical nerve stimulation. So some people may have heard of this. They're the little skin things you put on your skin, and it zaps you with that electric current. So that works through the gate pain theory. To basically, the idea overall is that there's only so much signal that can be sent through the nerves at one time. So if you block the pain signal with another signal, you reduce the pain. And so that may or may not work for the knee. Tylenol or acetaminophen, again, it depends who you ask. Same with acupuncture, glucosamine and chondroitin, nutritional supplements, and another one at the bottom that I haven't mentioned yet. It's called platelet-rich plasma, or PRP. Some people might have heard of that as well. It's one of the newer regenerative medicine therapies that are coming out these days. What that is you take your blood, it's put in a centrifuge, and you centrifuge out only the plasma and the platelets, and then you inject that into the area of pain or discomfort. That's a relatively new treatment. It's got some encouraging results, but there's a lot of things that are unknown about it in terms of like dosage, frequency, and just more studies need to be done. So there's potential for that as well, but it can't be said for sure. So it's an option. What we don't recommend, again, is the lateral wedge insoles, opioids, and then the viscosupplementation is the synthetic fluid in the knee. It's been done for a while, and it unfortunately doesn't seem to be having good outcomes overall. Again, depends who you talk to, so I'll leave it at that. And then sometimes you need a knee replacement, which we talked about a little bit briefly. Are there any questions about knee osteoarthritis? Otherwise, there's only a couple more slides. Yes, sir.
We have not liquid, but it swells up.
Yeah.
Fluid in it.
Fluid in the knee. So that can be associated with osteoarthritis or other, basically a lot of issues with the knee. So it depends on where it's coming from, and it depends if it needs to be removed or not, how much it's bothering, or how many symptoms it's causing. So it's quite common. It's about also finding out where it's coming from. Sorry, that's not a. Does that kind of answer your question, or not really?
Yeah, but it's very painful.
Yeah. So sometimes sometimes the fluid can cause a lot of pain, and so we'll stick a needle in and take that fluid off. And then hopefully, depending on what's going on, you can address the cause. Usually, well, I don't say usually. Hopefully, if you address the cause, it will prevent the fluid from coming back. But again, it really depends on what's going on in the knee. There's a number of disease processes that can cause fluid in the knee. So. Oh, yes, sir. Yes.
Yes. You have used the phrase from time to time, it depends who you talk to.
It does, yeah.
Could you also pose this from the point of view of if there is any science behind it?
Yes, there is.
Instead of something.
Yeah, so when I say that, what I mean is for some, there's a reasonable amount of consensus on what to use, but like there's a number of organizations that release guidelines on what interventions are useful for a particular, let's say, arthritis. So there's what orthopedic surgeons are recommending, there's what rheumatologists are recommending, and other organizations, and they don't always match up entirely, and so that's why I'm trying to let you know that some people will feel a certain way about certain things based on their interpretation of the evidence.
I'm not talking about feeling a certain way. It's just a question of, is there any science supporting one of these treatments or not?
Yes, sir, there is, yes.
So if you could say there is no science supporting this or not, that would be really helpful.
Okay. What should we go with? So the ones that I've had included on this have, at some level, a degree of science supporting it. So these, the level of evidence is variable. So I did not, sorry, you look confused.
Because What's it when it doesn't?
Okay, all right.
It's no man's land.
Sorry, I'm not trying. I'm trying to be as accurate as possible.
It's not so black and white.
That's the problem. Yeah, like it's not like if you want to talk about science supporting things, it isn't as you said. It's not always black and white, and that's why I'm trying to. I don't want to oversell treatments because that would be unfair and inaccurate. Because I don't want to leave you with an inflated opinion of what works and what doesn't. Because there's a lot of studies for a lot of treatments, and some things are more clear than others. But rarely is one treatment just so it must be done. Yes, ma'am.
There's also grades of evidence.
That's correct. Yes.
There's really good evidence for all the treatments on that slide.
Yes, this slide is what I'm trying to provide with the treatments that have the most evidence and the best evidence overall. Although there's still discrepancies. There's discrepancies in many areas of medicine, and that's why I don't want to give a black and white picture of things because I find that to be misleading, and I wouldn't want that for you. So, but I know at least people feeling, well, what do I do? So it's I hope, does that kind of explain why I'm saying what I'm saying?
That's the slide.
Yes, there's grades of evidence. So they've done lots of research studies, and they've shown in those research studies that these things listed on this slide will give you, generally speaking,
yes.
will give you good results.
These seem to have consistently good results overall. Consistently. Not guaranteed, but they have overall shown that they are reliable. I would say, how about reliable? Whereas the following slide, these are like uncertain as ones that it's really hit and miss, like can't tell at all. Some that are definitely not recommended, and this is just a note that operations are also a treatment option. Does that help a bit? Okay. So the last thing I wanted to leave you with was just a couple of just general things you can think about for bone, muscle, and joint problems overall. Relative rest. If you're injured, take a little break. You don't have to stop doing everything necessarily, but it's okay to back it off. As well, activity modification. So thinking about what we can and can't do, making sure our technique is good, that our exercise program is good, so how we're training, making sure our equipment and our footwear is good depending on the exercise that we're doing. Then, so from a physical intervention standpoint, thinking about what can we do for strengthening, how can we target the affected region, how do we progress that strengthening program with FitP, what kind of strengthening activities should we do? So typically, I think about it as closed chain to open chain. That's another concept I'm going to add. Closed chain is typically safer. That's where whatever you're exercising is fixed against a firm surface, so like the floor or a machine, versus open chain, which is like a free weight. And so closed chain typically provide more stability, more feedback from the joint to know where it is, and so are thought to be safer. But again, like I'm saying a lot, again, I apologize for that, but it depends on the context. Stretching is important as well. Proprioception retraining. So sometimes people can't feel their joint properly, especially after you've had some knee damage or some ankle damage. And so doing things like balance training, as long as you're able to do it safely, can help restore the positional sense of the knee. Because you want to make sure when you're using your knee that your knee knows and your brain knows where your knee is in space. Because if you don't have a good positional sense of your knee, you might be using it at an odd angle and causing a joint problem without even being aware of it. So you can retrain that, and it's okay to ask either your physician or if you have a physiotherapist or other health professional about what you might do if that's a concern for you. And then bracing, orthosis, so for the knee, for other joints, for foot, you can either have a brace or an orthotic. And then medication principles, so we talked about these non-steroidal anti-inflammatory drugs, tramadol, duloxetine, injections, and potentially Tylenol or acetaminophen. And then from a surgical standpoint, and a procedure, so injections. So again, corticosteroids, you really have to talk about that. They're not good for everything, and they have a risks as well, just like everything else. So worth a discussion.
What is the risk?
So the risks, anytime you put anything in the joint, there's always a chance of bleeding, infection. You can have some post-injection pain. Because you can have, after corticosteroids, you can have, if you have diabetes, you can have a flare of poor glucose control. Even though it's local, it still a little bit gets into the system. And you can have a little bit of skin changes, some blanching. There's a number of.
Are they used frequently for carpal tunnel syndrome?
Corticosteroids, they can be used for carpal tunnel syndrome. It depends on it depends on how severe the carpal tunnel syndrome is and as long as it's localized accurately, and as well as there's no other anatomical problems which might limit injecting that area. Does that answer your question?
Yes.
Okay.
Does it make the bone more brittle?
So in terms of the bone overall, not necessarily, but there's concern that overall the joint may deteriorate with corticosteroids over the long term. So whenever anyone's getting corticosteroid injections, it's important to space them out. So most providers will not do more than 4 per year to ensure that we're not inadvertently destroying the cartilage or the joint space by putting too much corticosteroid in there as well. So that is a concern. The evidence is it's not entirely clear, but there's concern about it. And so typically people are very conservative about injecting the joints.
Do the steroids stay where they're injected, or do they eventually flow to the body?
They stay mostly where they're injected, but again, as I said, there's very minimal systemic side effects from it. Again, like the higher blood glucose if you're diabetic is a known complication from corticosteroid injections into the joint. It can't all be kept in there, but the majority of it is, and that's why I say that systemic side effects aren't as much a concern. And then we talked about it, platelet-rich plasma. 2 more things I'm going to introduce that are new, and then that's the end of it. So whole blood therapy, it's a version of platelet-rich plasma where they just inject your blood into the area that's bothersome instead of centrifuging it. Prolotherapy is another area, we didn't cover it here, it's more for tendinopathies and other things, but it's an injection of a sugar solution and saline to try and irritate the area and restart a healing process. And then you have surgical options which include reconstructing the joint, taking some extra stuff off with debridement, either replacing it or even fusing it if it's becoming a problem. And I know that's a lot of information. Thank you for your patience. And if we have any more questions, I'm happy to answer them.
The question, you didn't mention arthritis in the scan. I would assume that what you had on the screen there is basically the same.
It's not, again, these are all, what I was trying to give you was some overarching principles. There's, as with many things in medicine and in life, once you get into the nitty gritty, there's all sorts of little nuances and little changes that are important to know about. So I didn't include, there's just so many joints in the body, I just couldn't cover everything. There are some things that are different for hands specifically in terms of its management plan, so there are. So that, if you want to talk about that in detail, either with, that would require a detailed conversation as well. Yeah.
What happens when your knees click, but you don't have any pain?
Okay.
It's inclined, knees, ankles.
Yeah, so clicking is not uncommon. It doesn't necessarily, the most important point is how much is it bothersome? Is it causing any pain or any discomfort, any instability to the knee? It's going back to the same principle of on the x-ray, things that aren't normal may or may not cause any symptoms or be a problem. And so if otherwise things are okay, note it. So it's important, I always recommend, in certain situations I want to provide reassurance, but not such that you're not vigilant and you're not paying attention. If something changes or things are different, then it's important to note that and see your healthcare professional to get the attention that you need.
My knees have clicked for the last 25, I'm 50.
Yeah.
And they've clicked for 25 years.
Sure. So noting such a long period of time, it's, keep an eye on it, obviously, you don't want to you don't want to go in and do something that could actually cause a real problem, right? So It's like a lot of people have another thing in the knee called crepitus, and that's where you just like, you put your hand on your knee when you're flexing it up and down, you just feel a horrible grinding sensation. Sounds like you got nothing left in your knee, like all your cartilage is gone, and like feels like it could be a disaster. But there's a lot of people who have that and their knee doesn't hurt, and so we just leave that alone. We monitor that, and if functionally you're doing okay, and it's not causing a big impact on your life, then more or less if it ain't broke, don't fix it, kind of thing, right? Yes, sir.
My rheumatologist, he would give me 2 cortisone needles for a year because I was considering it for plantar fasciitis.
Okay.
And he said that is no good for my weight, which you gain weight, for my blood pressure and diabetes.
Sorry, I don't know if I heard or understood the question. I apologize.
My rheumatologist.
Yeah.
He only gave me 2 cortisone needles.
All right.
For the whole year.
Okay.
I suffered plantar fasciitis.
Yeah.
And he said the side effects is not good for my blood pressure and for my diabetes.
Correct. Yeah.
So he just rationed me with that.
Yeah, I mean, again, a lot of the stuff we do in medicine is balancing the risks and the benefits, and so that's a conversation you can have with your rheumatologist about, how well your joint pain is being controlled and your other symptoms, and what risks you're willing to accept or not. So that's the conversation you just have to have with them about what is safe to do, because we don't. One of our number one jobs in medicine is to do no harm. So if we're not doing that, we're really not doing our job very well. But a lot of times it requires a discussion, because with a lot of interventions, medication, surgery, there's risks involved. So we're always trying to make you better as best we can.
He cut off his cerebrals. So I just had people bypass surgery.
Yep.
He said, no, it's no good for you.
Exactly. And again, it's about risk.
Side effects of that.
That's a problem. A lot of people with heart problems aren't recommended non-steroidal anti-inflammatory drugs, because they can have bad things for either the other medications that you're on for your heart, or for your blood pressure, or your kidneys, or your stomach. So again, it's about balancing the risks and benefits. It's just because something's not recommended doesn't mean it can't be done. But again, it's about having that discussion.